Hi, good afternoon, everyone. Thank you for joining me today. I'm Dr. Islam Saleh. I'm a pain management physician at OrthoVirginia in our Lynchburg location. Today, I will be talking to you about a topic that's pretty close to what I see on daily basis, almost at my clinic. It's about vertebral compression fracture. We're going to go through a few things today to try to understand this condition a little bit better and figure out what are the treatment options out there and what we can do to help our patients to hopefully prevent future fractures. Next slide. So vertebral compression fracture, we're going to try to understand the causes of this condition, recognize what the symptoms are and when to seek medical care, know what are the available treatment options out there, and then hopefully prevent future fractures. Next. So from the naming itself, compression fracture, you can understand or appreciate that there's something that is smaller than it should be. On the left-hand side, this is kind of like a side view of the spine. You can see the vertebral bodies, which are these square blocks that are kind of stacked on top of each other. And you can see there are, the vertebral bodies have these like similar heights from one level to the next. On the right-hand side, you can see there is one bone that looks actually smaller in height. Basically, it got compressed. That's basically what a compression fracture looks like in terms of an animation. Of course, it looks a lot more easier to describe on X-ray, which is something we're going to look at in future slides. But basically, the bone gets kind of squished up front. It's also what we call it a wedge compression fracture because usually the front of the bone is compressed more than the back part of the bone. So it looks more like a wedge. Next slide. So you can see on the X-ray over here, actually this arrow is pointing a little bit lower than what I aimed it to be, but basically it's the level above where the arrow is pointing at. You can see the bones. And again, this is a side view of the spine. The vertebral body are these squares of bones stacked up on top of each other. And typically they are equal in height from one level to the next. But you can see that there's one level that's wedged and the front of that bone has a lot less height than the bones next to it. So that's how a compression fracture looks like on an X-ray. Next slide. So what are the common causes for a compression fracture? Well, the most common cause by far is osteoporosis. And osteoporosis means that the thickness of the bone is not as it should be. The bone is a lot thinner than it's supposed to be. So if you think of our bones are like cinder blocks, they are as thick as a block. When you have osteoporosis, it becomes more like cardboard. The bone is much softer, so definitely it's much more prone to fractures. Traumas, of course, like high velocity injuries, especially like fall from a height or a motor vehicle collision can cause a compression fracture, even if in a young, healthy patient, they can also develop compression fractures due to a trauma. And very rarely we see tumors. Tumors can cause the bones also to weaken, and that can also predispose the patient to have a compression fracture in a bone that got weakened by a tumor, but that's pretty rare. Next slide. Now, what are the risk factors for osteoporosis, the most common cause for compression fracture? Well, as we all age, our bones would get softer. So typically after age 65, our bone damage or our renewal of bone tissue is a lot slower than our breakdown of bone tissue. So we cannot form bones as fast as we are breaking them down. So basically, our bones get softer with age. Females are definitely much more prone to osteoporosis than men, especially post-menopausal women are more prone to fractures due to hormonal changes, which makes the bones softer as we age. Smoking is also a big risk factor. It decreases the blood supply to the bones, and that makes our bones more fragile. And that's when we see patients at a younger age being more susceptible to compression fractures due to the bones getting softer due to smoking. And long-term use of steroids. And that's one of the reasons why, in terms of patients with chronic pain conditions, we don't like to treat them with long-term use of steroids because eventually over time, it can weaken the bone and predispose patients to compression fractures. Same as conditions like asthma or rheumatoid arthritis, which unfortunately can get treated with long-term steroids, and that can cause also osteoporosis. Next slide. So what are the signs and symptoms of compression fracture? Well, the thing that would definitely grab the attention of most patients is sudden onset of pain. So when you have pain that you didn't have like an hour ago or a day ago or a week ago, pain that starts all of a sudden. And a lot of times, because most patients who have these compression fractures are elderly patients. So these are patients who are used to everyday pain symptoms, like they wake up with a little bit of achiness in their back, or they have back pain when they're doing some activities. But this is a different kind of pain that they did not experience before. This is kind of on top of their everyday pain symptoms. So a lot of times patients would come to me in clinic and say, I was loading a dishwasher or taking out dishes or fixing breakfast, or even like turning around the bed. It doesn't usually come with like a major trauma. It usually happens with like a very small like activities of daily living that causes this sharp, sudden pain that the patient didn't experience before. And that's usually the sign that will kind of draw everybody's attention. And that's when patients need to seek medical attention. Now, height loss and stoop posture, these are things that happen over a period of time. You can imagine if you have multiple of those bones slightly compressed forward as we age, and that happens even with osteopenia or osteoporosis, eventually can lead that to that increased curvature of the upper back that we see a lot of our elderly patients have. And very rarely it can cause leg pain and leg weakness. When this bone fractures, occasionally the bone can buckle backwards towards the nerves in the spine and can cause pressure on the nerves going down the legs. That's again pretty rare. It doesn't happen too often. Most of the fracture happens in the front of the bone, and we don't see as much leg pain or leg weakness, but that's something that can happen in rare cases. And that's something that also kind of grabs patient attentions and requires like medical intervention. Next slide. So when to seek urgent care, obviously if you have sharp onset of pain, whether it came with any significant trauma or not, that's something that grabs most of our people's attention. And I think at that point, you need to go see a physician to see what's the cause of this pain. Weakness, of course, if that happens in the lower extremity all of a sudden, and that's a sign that also you need to go see a physician at that point. And a lot of times the weakness happens just because of pain. When we're in pain, it's hard to kind of use the best strength of our muscles and we're just weaker just because of the pain. But occasionally, as I said, it could be true weakness from damage to the nerve going down the legs. And then loss of control of bowel and bladder, which again is a very rare finding with compression fracture. Next slide. So the diagnosis when I see a patient in clinic and I have a suspicion of compression fracture, that starts with the history part. When a patient comes to me and they said like, I have this sudden sharp pain that started usually with like very limited trauma or injury, that I didn't have this pain a week ago or even like a day or two ago, that already draws my attention that could be a compression fracture. Especially if it's in an elderly patient, I would think right away that this could be a compression fracture. On physical exam, we started with like, again, the posture of the patient. If they are trying to lean more backwards, which is a sign that they are not trying to put too much pressure on that fractured bone. So any pain with bending over or leaning forward, that's a sign that this could be a compression fracture. And then you want to look for any findings like weakness in lower extremities on exam. And then we move on to imaging with x-rays and MRIs and advanced imaging, because that can help us figure out, first of all, if the patient has a fracture or not, and then if this fracture is old or a new fracture. Next slide. So again, the imaging modalities that we have, first of all, an x-ray. A plain film is very helpful because that, again, tells you whether there's a fracture or not. For the most part, you can identify even mild fractures on x-rays. MRIs are very important tools, and we're going to go through some slides. The MRI, the most important thing to know about MRI, it can help you differentiate between a new fracture and an old fracture, because the x-ray will always look the same. And by that, I mean, like, if you develop a fracture in the spine, unfortunately, our body is not able to heal that bone to make it look back like normal bone. It will always look like it's fractured, even if it was treated. So an X-ray alone cannot tell you how old or new the fracture is. And for some patients who have like pacemakers or defibrillators or any other metal in their body that they are not able to get an MRI, we end up combining a CAT scan with a bone scan. The combination of these two studies can give you the information that you need to get from an MRI. Basically tells you if there's a fracture and gives you kind of like more of the dimension of that fracture and more details with a CAT scan, and then comes in the bone scan to tell you if this fracture is old or new. And the last thing is bone density, and that's very important in the sequence of treating this problem to hopefully prevent any further fractures in the future. Because yes, we're having a compression fracture that we're dealing with acutely at this point, but we want to prevent any further fracture in the spine or in other areas of the body part. Basically, wrists and hips are also very prone to fractures with osteoporosis. So this is how an X-ray looks like for a patient who comes in and tells me that they have the acute lower back pain. If you look at this, this is a side view of the spine. On the right side of this picture, these are the bones of the lumbar spine kind of stacked up on top of each other. The last square that you can see, that's the lumbar number 5, and that's a full square. The bone above it is the L4, and you can see there's quite a bit of compression of that bone. It's a lot smaller in height than the one above it and the one below it, because the L4 in this case is fractured. If you even go higher up in this picture, so the L1, the lumbar number 1, at the very high end of this picture also has less height than the one below it. So that's also a fractured bone. So this is a patient that has an L1 and an L4 compression fracture. And again, with this picture, you cannot tell if it's old or new. Now, moving on to the MRI picture, that is like the dramatic difference that you can see or tell if this is an old or a new fracture. This picture is kind of looking the other way around. So the abdomen is on the left-hand side, the back muscles are on the right-hand side. And this is a side view of the spine. This is a specific sequence of the MRI that we get when we are concerned about inflammation, anything that will have fluid inside it, and that's associated with fracture or infections. See, if you look at the left side of this picture, the vertebral bodies are stacked up on top of each other. These are the black structures that you see on the left side. The white in between the black, that's the discs, and that's how healthy discs looks like on the MRI. If you look at the top of this image, there's a bone that looks white on the inside, and it has less height to it than the other bones. And this bone looks like a little bit more like a bow tie. And that's how the compression fracture looks like on an MRI on a side view on this specific sequence. So whenever we're concerned about a compression fracture, we ask specifically for this sequence of the MRI because it can easily identify a recent fracture. And again, on this picture of the MRI, this is a very recent acute fracture of this bone. As time goes by, this bone that is fractured at the top of your image, it will continue to look the same in terms of its height. So the structure of the bone will not change even as this bone heals. It will never go back again to looking like the other bones, like a full square. It will always look like this bow tie or wedged bone. But what will change over time is the color inside this bone would change to be black like the other bone. And that's how an MRI can tell you a very recent fracture or an old fracture compared to the X-ray that would always look the same. Next slide. Now, bone density can help you identify like the underlying cause of this fracture. Again, elderly patient, you can suspect that they have osteoporosis. And that's where I see that there's a huge missed opportunity. I see patients in their like mid-70s and early 80s. And the first time I see them is for like this acute onset low back pain or mid back pain. And I ask them, what was the result of your last bone density? And a lot of times I'm surprised that they tell me that they've never had a bone density in their life. And bone density, according to recommendation by the CDC, is to be obtained at age 65 and every other year, even if it is normal. And in female patients, it can even start earlier, right after menopause. That's when we know that the bone density starts to drop really quickly. So the low bone mass is like the lesser form of the disease. The osteoporosis is the actual condition where it needs to be treated with medications. So the bone density testing is mainly for future treatment and prevention of further fractures. Next. So the treatment goals, when I see a patient with an acute compression fracture, because that's the only fracture that's indicated for an acute treatment. The chronic compression fractures, we don't treat them. Acute compression fractures, the treatment goal are initially to reduce the pain symptoms, of course, but you also want to restore function and mobility as soon as possible. And of course, we want to prevent future fractures. When I talk about function and mobility, it's very important because a lot of our elderly patients, when they come see us for acute condition of back pain, they come in our clinics in a wheelchair. And I always ask my patients, if I've seen you last week before you developed this pain, would you have come in my clinic in a wheelchair or would you have came walking? And most of the patients would say no. I would have been probably walking to your clinic. I would not have been in a wheelchair. And for me, that's a dramatic shift. Walking from a car to see me in my clinic is probably less than 100 yards. And not being able to walk 100 yards, that's a significant decline in function. And elderly patients are good at kind of living with pain and adjusting their activities. And that's one of the things that worries me the most because yes, they might not be in significant pain while they are sitting and being wheelchaired around. But if they get up and move, they are in significant pain. And that leads them to be like much more sedentary. And a lot of times that leads to significant weakness in their legs, which we want to kind of get that strength back again as soon as possible. Next slide. So the treatments kind of breaks down into two brackets. We can try conservative measures with bracing and medications and physical therapy to try to mobilize and improve strength early on. Or we can do interventions with these two procedures, vertebroplasty and kyphoplasty, which we'll talk about in more details. Next slide. So this is the back brace that we order for patients. Most of the compression fractures that we see in the spine, the majority of them are between T10 and L3. So these are like 6 segments in the middle of the trunk. So this is the brace that we would order for these common compression fractures. Now this brace is pretty bulky, and unfortunately a lot of the patients that we see who have compression fractures cannot even fit in this brace. They have a significant upward curves in the upper back that is very difficult to fit their chest into this brace. So what I tell all my patients is go try out the brace before you commit to taking it home. The brace can help pain for patients who can't tolerate the brace wearing it almost the whole day for at least 6 to 8 weeks. But patients who cannot tolerate the brace, it becomes very difficult for them to even get fitted in this brace. For patients who can tolerate it, it can help stabilize that segment that has the fracture and decrease the pressure on this area. That's kind of more of a reminder not to bend, twist, or lift, which are the activities that can cause significant increased pain. Next slide. Medications kind of break down into 2 categories. One is this medication called calcitonin. Calcitonin is an old medication that we used to use for osteoporosis treatment long-term. We don't use it now for chronic treatment of osteoporosis, but for acute compression fracture, we have studies that shows that it can help decrease the breakdown of the bone and can help with pain symptoms in the first 6 to 8 weeks of a compression fracture. There's not really a lot of contraindication or interaction between this medication and anything else. The only problem is patients who have seafood allergies because this medication is dried from salmon. Pain medications, we try not to be very heavy on prescribing pain medications to our patients with compression fractures because a lot of them are elderly patients and sometimes their fractures happen because of an episode of falling or tripping over something. And if you can think about it, if I add a stronger pain medication, a lot of the side effects of these medications can cause even more dizziness or decreased balance. So we want to try even start with Tylenol and very mild pain medications and kind of go off from there as depending on the patient tolerance to these pain medications. Next slide. Physical therapy, initially we try not to mobilize the segment that is fractured. So a lot of times if I'm going to send a patient to physical therapy early on, I want them to be wearing the brace. The brace is, first of all, to help the patient not bend, twist, or lift, but it's also a good reminder for the patient and the therapist that they are there to help with their mobility and strength in their lower extremities for the most part, and then work on the things that probably have maybe contributed to their they're falling or injury or balance problems. So I want them to work on balance and posture to help with that fracture segment and hopefully prevent future fractures. Next slide. To talk about interventional procedures, so for patients who are either in severe pain when I initially see them in the clinic, or we try the conservative measures for like a week or two and their pain has not been improving, we discuss the possibility of intervention. So the two interventions we have for compression fractures are either vertebroplasty or kyphoplasty. And the difference between them is not significant. So on this picture over here, what we see is a demonstration of a vertebroplasty procedure. So you can see on the right-hand side, there is this bone that has like these small lines running through it, which are like a presentation of a fracture in the anterior portion, in the front part of the bone. The goal for the vertebroplasty is to inject cement in the spine across this fractured area. And the way to achieve that is by introducing a needle, definitely a little bit bigger needle than a regular needle that we use in a clinic to inject a muscle or a joint. And that needle is introduced through the bone and it's done under X-ray. Typically, we use 1 or 2 X-ray machines in order to guide our path into the bone. And we go all the way to the anterior part of that bone where the fracture is. And under live X-ray, we can inject cement at a very slow pace and see where the cement is spreading across that fracture line. The cement is like toothpaste consistency outside of the body before we inject it. But as soon as we inject the cement, it hardens inside the body and it becomes as strong as the bone. And basically what the cement does is 2 things. It holds the fracture segments together, so basically it prevents that friction across the fragmented bone. And at the same time, it kind of cauterizes the bone on the inside. We have nerves that run inside our bones, and those nerves kind of transmit the pain signals from these fractures from nearby areas in our spine as well. And the cement has like a thermal effect, kind of like a cauterizing effect on those nerves. So it kind of helps decrease the pain by that effect as well. The other procedure that we can do for the compression fracture, and before I move on to the next slide, this injection of cement in the spine is typically done under moderate sedation and lots of local anesthetic. We don't do these procedures under general anesthesia. And the reason for that is because a lot of our patients who have these compression fractures are elderly patients. So we don't want to expose them to the possible risks of general anesthesia because they already have a lot of comorbidities. And unfortunately, the bones are too soft. So it's not really difficult to get a needle inside the bone, unfortunately. So most of these procedures are done under moderate sedation in the office, outpatient procedures, or at the surgery center. And it takes about like a half an hour to 45 minutes and maybe another half an hour for recovery from the sedation. But for the most part, patient is awake and interacting with us during this procedure. Next slide. So the second way of treating these fracture is same as the last slide, a needle inside the bone. But before injecting the cement, we inflate a balloon. The purpose of the balloon is 2 things. One is to try to restore a little bit of that height of the bone that got compressed. So you try to inflate the balloon and create some more of that height back again to the bone. But the main purpose of the balloon is to kind of push all this kind of fragment and soft bone segment to the periphery of the bone. So you create a cavity inside the middle of that fractured bone so you can inject the cement. One of the problems we have with injecting the cement is that the bone is so soft, it's like a sponge. So when you're injecting like toothpaste inside of the sponge, it can leak outside the bone. Even like the outside shell of that bone is so soft that the cement can leak through it. So in order to prevent that, inflating that balloon help kind of compact all that soft bone to the periphery and give you that nice space to inject the cement without allowing it to leak outside. So that's typically what most of us do for these procedures. We typically do this, what we call balloon kyphoplasty, to kind of minimize the risk of the cement leaking outside the bone. Next slide. And that's how an x-ray would look like after injecting a cement. So you can see all the bone has like one kind of specific color. There is one bone in like the upper part of this x-ray that has this kind of deeper white color inside it. And that's how the bone cement looks like on an x-ray immediately after the procedure or years after our procedure, because our body cannot absorb the cement. So the cement stays in place. There's no allergy to cement. It doesn't interact with anything. And you can see that the height of this bone is still not the same as the height of the other bone. It still looks smaller than the other bones. But the cement is sitting there in that front aspect, that anterior aspect of the bone to kind of help stabilize that segment from compressing even further. And this cement positioning is really good. It's in the front of the spine because you don't want any cement in the back of the spine because that can compress on the nerves going down the leg. So we want the cement in the most like front anterior part segment of the spine. Next. Surgery. Well, surgery is extremely rare in compression fractures. Most of the time is not indicated at all. And also one of the reasons we shy away from surgery completely, first of all, the bones are very soft. So putting screws through soft bones is very difficult. You cannot stabilize the screws too easily inside the bones. The second reason, again, a lot of our patients are elderly and they actually don't do too well with these surgeries because these require general anesthesia. So the only reason for surgery is what we call nerve root compression. So you can see the segment in the middle of the picture where, again, the bone is compressed and it has less height than the bones above and below it. This bone can occasionally buckle backwards. And if you think about what's sitting behind these vertebral bodies, behind these bones, are the nerves going down to the lower extremities. So occasionally we have a bone fragment that is protruding backwards and compressing significantly on the nerves going down the legs and causing either leg weakness or loss of control on bowel and bladder. That's when surgical interventions are indicated. And in that case, we actually cannot push this bone back in place. What we do is we decompress the spine. Basically, we open up the arch of the spine in the back part of that spine. So we give more room for those nerves. And then we have to stabilize the segment that's fractured by screws and rods above and below that fused segment, that fractured segment. And sometimes we inject cement either at the level of the fracture or above and below. It depends on how soft the bones are in those segments. But again, it's extremely rare to do surgery for compression fractures. It's less than like 1% of our patients who ever indicate surgery for that. Next slide. So recovery time, I see patients usually in the first week or 2 weeks at most from these compression fractures. And of course, that's the time where the patient have significant amount of pain. And they ask me how long does it take before this pain gets better? I tell most of my patients, whether we treat this with conservative measures, wearing the brace, trying the therapy and taking the pain medications, or we inject with cement, in any case, most of the pain is going to get better between 8 and 12 weeks. Well, that's a long period of time. That's 2 to 3 months. And my biggest concern in elderly patient is where their function deteriorates so much. A lot of our elderly patients, over 75, our ability to regain muscle strength after being sedentary and sitting around for a while is very, very limited. So once they lose this muscle strength, it becomes very hard to build it back up again, even after the pain subsides. So again, the first 8 to 12 weeks is where we have most of the painful symptoms. The bone healing can take even longer than that. And we know that from patients who we get MRIs down the road, and we can see that this bone is still inflamed, even sometimes up to 4 to 6 months down the road. But we're not treating the inflammation inside the bone as much as we're treating the pain symptoms. And that's between 8 to 12 weeks. The biggest difference between treating with conservative measures and doing the injection with the vertebroplasty or kyphoplasty is once you inject that cement inside the bone, you stabilize that level and you almost see immediate reduction in the pain symptoms after these injections. Not every patient requires an injection with cement. I mostly tell my patients, if the pain is not too bad and your function is not too bad and you're able to participate in therapy, then we can just go on with the brace and pain medications and we'll get significant improvement with the pain symptoms. But if their pain is significant enough that they are unable to tolerate therapy, or they are just like taking pain medications around the clock, then those are the patients that we recommend injecting with cement immediately, just to kind of increase their mobility and recovery time as quickly as possible. Next slide. So prevention for future fracture is very important. As I mentioned, a bone density is very important. Even for patients out there, if you're listening to me, before having any compression fracture, if you're 65 and above, or for female patients who had early menopause, ask your primary care doctor for a bone density exam. It should be done as part of your wellness check. It should be done every other year, even if your bones are healthy and normal. Quit smoking. For the smokers out there, smoking significantly decreases your bone strength, especially for people who smoked for over like decades. And it's never late to quit smoking. Even at an older age, if you quit smoking, your ability to rebuild your bone back again is much better. Exercise is one of the things that we cannot say enough. It can help build up strength, either weight-bearing exercises or just going out to exercise at the gym with resistance-based exercises. For the elderly patient, you can just routinely take vitamin D and calcium. They can help you build up your bone. For patients who have low bone mass, you can take them. Osteoporosis requires medication management with your primary care doctor. So we'll be moving on to answer some questions now. We'll try to answer as much as I can as our time allows. So we got a few questions through our live feed over here, and some questions that were sent out earlier. So this question says, is it common to have pain from a compression fracture still years after an incident? We think that chronic compression fractures do not cause pain. Compression fractures that happened years ago usually are not painful. In that case, we look for other sources for the pain symptoms, whether it's arthritis, disc degeneration, disc bulges, spinal stenosis, sciatica, but usually chronic compression fractures don't cause pain. Next question. Can this procedure be performed on the neck? I would say yes, but extremely rare. So the injection of cement in the neck is a very challenging procedure. The reason is the bones get a lot smaller. So the tools that we work with are significantly large, and they are designed more for the mid and lower back. So not typically in the neck, but they can be performed in very selective cases. I think at this time, we're going to have to conclude our live feed over here. But please, if you have any questions or any concerns, you can come see care at our clinics. I'll be more than happy to try to help you with any of these conditions of your spine.